Two. Hi, good evening. I'm Laurie Chungone, the service line leader for Women's and Children at Inspira Health Network. Thank you for joining us tonight. Our presentation is brought to you on behalf of the Spirit of Women program we have at Inspira. This program allows us to bring to you many timely topics with information that you can use, and hopefully you'll have some fun while learning. The purpose of today's program is to provide you with an overview of osteoporosis, how that can play a role in fragility fractures, and some recommendations on how we can help keep ourselves as safe as possible. The presentation is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health professional with any questions that you might have regarding any medical conditions. You may know this already, but we cannot see or hear you. The only audio and video that is turned on right now is by our panelists. On your screen, you'll see a box labeled Q&A. Feel free to submit your questions throughout the presentation and we'll address as many as possible at the end. Your questions will only be visible to us. So if you'd like to keep yourself anonymous, just click the button that says anonymous before submitting your question. Throughout the presentation, you'll see some poll questions pop up on your screen. We encourage you to participate. It's what makes this fun. You'll receive an email after the event with a recording of the webinar. So to get us started, I'm pleased to introduce our speakers today. First, we have Dr. Eddie Wu, who is a board-certified, fellowship-trained orthopedic surgeon specializing in total hip and knee replacement. He obtained his master's degree in physical therapy from the University of the Sciences in Philadelphia and went on to complete his medical degree at the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. He completed his internship and residency in orthopedic surgery at UMDNJ. After medical school, he completed his fellowship at the Rubin Institute for Advanced Orthopedics at Sinai Hospital in Baltimore, Maryland. He currently serves as the Chief of Orthopedics at Inspira Mullica Hill and specializes in adult reconstructive and orthopedic surgery. Dr. Wu has a special interest in minimally invasive surgical techniques to treat his patients and one of the few surgeons in South Jersey who specializes in the Mako robotic assisted technology. Thank you for taking the time out of your busy schedule, Dr. Wu, to be with us, and welcome.
Thank you. Thank you for having me. Very pleased to be here.
Very good. Dr. Bach Wen is our next panelist. He's a primary care physician and medical director at Inspira Medical Group Primary Care in Medical Hill Commons. Dr. Wen earned his medical degree from Brown University School of Medicine and completed his residency at Christiana Care Health System. He is board certified by the American Board of Family Medicine and has a special interest in sports medicine, aesthetic medicine, asthma and allergy treatment, adolescent health, and preventive medicine. Dr. Wen is also the patient-centered medical home director for all Inspira Medical Group primary care locations. He was named one of Philadelphia's best physicians in 2019-20. Welcome, Dr. Wen.
Well, thank you very much. I'm glad to be here. And again, thank you very much for inviting me today. I am very excited to present this very, very important topic. And so let the show begin.
Very good. We also have Merle Willenmeyer. She's a physical therapist who's licensed, graduated from the University of Hartford in Connecticut, is ASTIM certified and a certified workman's compensation specialist. She is very well versed in the treatment of a variety of acute and chronic orthopedic and neurologic conditions. She has implemented various therapeutic programs for sports rehabilitation, joint replacement, concussion management, postoperative care, lifestyle management, and much more. Thank you also, Merle, for being with us today.
Thank you for having me. It's good to be here. Thank you.
We start our program off today with a poll question to see where you are and where we may need to go with today's discussion. So our first question is a true or false question. Your endocrine system can be the root cause of osteoporosis. True or false? Your endocrine system can be the root cause of osteoporosis. We'll give you a second to answer and then we'll see where you are. Okay, so 83% of you think that the endocrine system is and can be the root cause of osteoporosis. We do hear a lot about hormones in all aspects of our lives, especially as women. Let's have Dr. Wen explain to us what the endocrine or hormone system is and how that can play a role in our bones and our bone health. Dr. Wen?
All right. Yeah, thank you very much. Very, very nice introductions, and nice to meet you all this evening. And I'm glad to have this opportunity to be here with you and talk to you about osteoporosis. So with the poll question, well, the short answer is yes, but it's actually a very, very complex system. And basically, an endocrine system is a system that composes of many, many different parts, and it produces various type of hormones, and many of them you may have heard that already many times over the years. One is testosterone, the other one is estrogen, progesterones, and thyroid hormones and parathyroid hormones, growth hormones that we have is coming from our brain or pituitary brain, and so forth. So they certainly play a very, very important part in regulating our, total health. But they also play a very important part in our what we call is bone structure and strength.
Very good. As women, most of us have heard the term osteoporosis and know that it's a disease where the body loses too much bone, makes too little bone, or both. Many of us have this condition, and it may run in our families like mine, where both my mother, my father, my grandmother, my sisters, myself, all have osteoporosis. Can you explain to us a little bit more, Dr. Wen, about what osteoporosis is and how it can affect us?
Okay, so osteoporosis, and by the name, if you separate it out, osteo literally means bone, and porosis means porous. So that means that your bone just have way too many holes in them, and it's because when they have too many holes, they make them spongy-like, and they are weak, and as a result, they are more prone to fracture upon stress. For example, when you are falling and you're hitting certain hard surface, you're bound to break, and sometimes even just simple as coughing can result in a rib fracture and so forth. So osteoporosis is a condition where the bone is weakened because of so many holes, and they thin out, and as a result, they are fragile and they're easy to break. Okay. So there are certain facts about osteoporosis, as you can see on the slide here. Up about 25% of women by the time they reach 65 or so, they have osteoporosis. Fortunately, though, men is much less frequently affected, only about 1 in 20 at age 65 or older. Now, this is caused by various factors, and then because as we grow, we develop and we make bones. When we build bone, we bone, but then as we get older, we also lose bone. So your body is constantly changing and remodeling itself. So if you building faster than you lose, you build stronger bone. If you lose bone faster than what you can make, you end up with weaker bone over time. And unfortunately, by the time a woman reach their menopause, the first a couple years after menopause, they lose bone very, very fast, a lot faster than the body can make up bone. And as a result, you can get this disease called the osteoporosis. And unfortunately, it is often called a silent disease because many people do not have any symptom from having thin bone themselves. The only time they get is when they have a significant injury or fracture of the bones. That's what they, when they found that they actually have osteoporosis. So that's why it's very important to screen and intervene early before a bone is broken. Okay, so just an overview of this, what you can see, most of the time our peak bone mass reach when you're about 30 or so, and around when you're 50 years of age, the bone building part of it is actually less than the bone loss part. It's basically a wear and tear, or if you would refer to as called rust and erosion of metal. At a certain age, you start to lose bone faster than what you can make. And currently, there's about 10 million Americans actually living with osteoporosis. And as you can about, for some reason, my screen is a little bit off. View. Okay, I got it. So it's about 44 million Americans have low bone density. Okay.
And how about, about the annual cost for the country, about
so currently it is estimated about $19 billion. And I think that figure is a little bit on the low side. But if you can imagine $19 billion just to treat osteoporosis or fracture itself. And if you can imagine, if you count 1 second for every dollar, you know how long it would take? 31.7 years to count to $1 billion. So $19 billion, that is a heck of a lot of money just to treat osteoporosis. And that is just the financial cost of treating osteoporosis and the fracture. There's a lot going with that as well. Social quality of life that is lost with bone fractures and so forth. So that's why it's very, very important for us to intervene and prevent osteoporosis.
So you mentioned osteoporosis is silent, or we wouldn't even know we had it, right? Because it's in our bones.
Yeah.
Are there other signs that we should look for or, find out about?
No, oh, absolutely. So as I mentioned before, osteoporosis is called a silent disease, or it's called a silent thief, because the vast majority of the time people actually don't know they have it, but there are certain signs. So symptom, that's something that you can feel. Sign is something that we can see and observe, and you may not feel it, but you can observe. So you start to see many people, they have the back or the postures over time, they just do this slowly. And that is the sign of, what we'll call is tiny chronic fracture of their spine, and those are what we call asymptomatic. They do not have any symptom. And as a matter of fact, about 2/3 of spine fracture in this manner do not have any symptom. And only about 1/3 when they sustain a significant large fracture, that's when they have significant pain. But yes, these are certainly a very, very concerning sign that somebody who's having trouble with osteoporosis over the years.
Merle, Dr. Wen just mentioned about posture. Can you tell us what concerns people in your practice and what maybe people can do about it?
Yes.
Yeah, so many people say, well, hey, I'm too old now, and I don't know if I can do anything to improve my health. Well, osteoporosis can be intervened, and there's many ways that you can actually improve the bone density and thus the strength of your bone. So you have a regular visit with your provider, and there are physical examination, and we can do certain tests to screen for your bone densities. And the most common one is called a DEXA, which is DEXA, which is it's a scan. It's called dual energy X-ray absorptiometry, and that can measure the bone density. There are various testing that we can do. Actually, MRI can do it, CT can do it, even some specialized ultrasound. But the best one to do now is it's called a bone density test. It's called a DEXA scan.
Thank you. How about Merle, in your practice, what concerns people with some of this stuff, especially things like poor posture that happens?
I would say, one of the questions I get almost all of the time from patients when I'm evaluating either their neck, their shoulder, or their upper back area is they'll always say, what is this bump back here? Why do I have this bump back here? I think it just bothers them. It makes them uncomfortable, and they're wondering why it's there. I think actually Dr. Wen did a great demonstration of that hunched over positioning that causes some of that appearance back there. And so what I tell them is that it's mostly a kind of combination of things that causes it. It could be the microfractures that Dr. Wen mentioned. Sometimes in my experience, if someone doesn't have fractures yet, it might also be just a limit in their joint mobility, especially for the lower thoracic and the upper thoracic and the lower cervical area. So it could be a joint mobility restriction that can be worked on with manual therapy and stretching and posture training. Sometimes it's just bad posture. Maybe years someone worked at a desk, they're always rounded, they're always forward, and they didn't do enough in the opposite direction. So it can also be just a weakening of some of the posterior spinal muscles as well as the scapular muscles. So if they're weak in the back, they're going to tend to be more rounded. Whereas if we're stronger, we'll tend to hold ourselves more upright in a better position. So I think if they have kind of a mild little bit of a bump there that's making them uncomfortable, some of that can be improved with posture training, with joint mobility, exercises and manual therapy, stretching, strengthening, things like that.
Thank you. I don't know if everybody else is doing this, but I'm straightening up. So let's ask our audience another poll question. And this is true or false. At age 60, there's really not much that can be done to improve our bone health. So 60 and older, obviously, once you get to a certain age, is it true or false that you really can't do anything to improve your bone health? So we'll give everybody a second to respond, see what everybody thinks. And then we'll see if there's anything we can do. Okay, 96% think that false, there's nothing you can do. So obviously there's stuff that we can do. Dr. Wen, what can we do to prevent osteoporosis?
Well, actually, there are a lot of things that we can do to treat and prevent osteoporosis. So obviously, first thing first is basically a balanced, healthy diet and exercise. Regular, what we'll call is weight-bearing exercises and strengthening exercise. As you know, the athletes do not get big and strong by eating and sitting and watch TV. They train, right? So your body responds to that, what we'll call physical stress. If you do a lot of hard work, your hands become calluses. And that protects your skin from getting ripped out and forming blister and so forth. So your bone do the same. So when you have regular exercise, you can strengthen the bone. And obviously what you eat also matters. Don't smoke. People say, well, why would smoke cause osteoporosis? Every time when you smoke, it shrinks the blood vessels. And the blood vessel, the bone, especially your spine, they're very, very small bones, and you have less blood. If you have less blood, you're going to have weaker bones over time. So the same thing with alcohol consumptions and so forth. All those things can negatively affect your bone health. Make sure that you get adequate calcium, fresh fruit and vegetables, and so forth. So many of these so-called dietary and lifestyle can actually improve your health, bone health significantly. And then with that, after that, you screen, and if you have osteoporosis or osteopenia, which is a thinning of the bone, we can actually treat you with calcium supplement, vitamin D supplements, and even medication that we need to make sure, especially in some what we'll call ethnic groups are more prone to osteoporosis, especially when you're fair skin, you don't have a lot of sun exposure, you have significant trouble with absorbing calcium because you don't have enough vitamin D. And where we live in the Northeast here, most of the time we are hitting on the inside. We're doing our work. Even it's like working people, they work indoors most of the time, and over the years it pile up with a little bit of damage over time, and it causes you to have thinning bones. Okay, so are there ways that we can actually treat the bone? Yes. So as I mentioned before, the bone health is basically based on how much bone you can build and how fast your body actually breaks down your bone. And so we can say, well, if we can prevent the bone loss, just the same as if you have rust and corrosion from the piece of metal you have, what you can do is actually clean it up and paint it. And that will probably slow down the rusting and the corrosion from your metal. And treatment of your osteoporosis, we can do the similar way, so that we give you medication to prevent the bone loss. And then the other part, we're going to also give you some medication that actually keep building bone. So you're treating both ends, and as a result, you can improve your bone health. And you can see over here that when we talk about the weight-bearing exercise benefit and so forth, that's also the typical diet. The Mediterranean diet has been shown to be quite beneficial in building healthier, stronger bones.
I know myself and my own family, we've had a number of people who've had compression fractures from the osteoporosis, femur fracture. Dr. Wu, can you give us a little insight?
Sure. So, I mean, unfortunately, when people have fractures, it's after the fact that, whether they've been diagnosed with osteoporosis or not, it's already, sometimes it's too late, because when they have the fracture, that's when they present to someone like me. And by definition, they have an osteoporosis or fragility fracture, which would include things like vertebral compression fractures, which may cause you to become more hunched over, or wrist fractures or shoulder fractures, or God forbid, hip fractures. But Certainly, once osteoporosis occurs and there is a fracture, that's where someone like an orthopedist comes into play.
Thank you. Merle, how about what physical therapy exercises could we or should we do, and maybe those we shouldn't as well?
So I know Dr. Wen was talking a lot about building bone and what we can do to build bone. So I think, from a physical therapy standpoint, that is our main focus when we're talking about osteoporosis prevention, is just building stronger bones. So that's the main part of what our part is. I think it's important for us to understand that our bones are actually living organs. I think sometimes when I picture a bone, I always picture my dog's bone, which is very dead and not doing anything other than being chewed on. But our bones are living organisms, so we can make them stronger, we can make them weaker by the things that we do, what we eat, what we do. Kind of like we exercise to strengthen our hearts, we can exercise to strengthen our bones. So from physical therapy, we are part of that bone building part. And just like Dr. Wen also said, if you sit on the couch all day, your bones are only going to be as strong as the activities that you do sitting on the couch, like your remote control. But if you are someone that goes to the gym, or you exercise, or you go and you walk with your friends a couple times a week, you challenge yourself, then your bones are going to build to those types of activities. So we want to build strength in physical therapy. So what can we do to make our bones stronger? We can do weight-bearing exercise, walking, climbing stairs, squatting. Those are all weight-bearing exercises. We can also do upper body weight-bearing exercises. So things like holding a plank or doing a push-up are all weight-bearing exercises. You can, if you're not someone who's comfortable going to a gym, or if you're not sure what to do, I think physical therapy is a great option as far as meeting someone who can give you a very specific program that is safe for you, especially if you are someone that has osteoporosis or osteopenia, or if you think that you might be at risk because of your family, like Laurie. So seeing your physical therapist is a great way to learn a safe program. Muscle strengthening exercises is another thing that we can do. You can use different things for that. So I kind of brought some toys over. We have some just elastic bands. You can use things like that to help build stronger bones. You can, if you have small weights at home, you can use things like that. So anything, free weights, elastic bands. If you have exercise equipment, that's great, but not always mandatory, because you can also use your own body weight for resistance. Another thing we might work on is core stabilization exercises. We want to do that in order to improve our posture, improve our balance. If we have a stronger core and better balance, less risk of falls and injury and fractures. And also some different types of core and stabilization. You could use yoga or Pilates. There's some really great exercises in those types of programs that are safe to do, that are going to incorporate flexibility, strength, as well as weight bearing. So I think those are all good choices.
Mm-hmm.
And then as far as what to do, as far as what to avoid, if you have osteoporosis, things that you should not do, high impact exercise should certainly be avoided. An example of that might be running. Jumping on a trampoline with your grandkids might not be advised if you have osteoporosis or osteopenia. Anything that involves excessive bending, whether it be excessive bending flexion or bending extension, those are some things that you want to avoid. Or activities that require extreme twisting. Tennis is probably a good example of that. If you have never done tennis before and you are osteoporotic, and then you try to go and do those large twisting type movements, might be a bad idea. And also certain Pilates and yoga moves might be not appropriate for someone who has osteoporosis, mostly because they might require some excessive spinal motion. So there are some exercises in Pilates and yoga that have more of what we call a neutral spine, a little bit more in the middle. But there are also some that might be more dangerous to someone with osteoporosis if they are in, too far an extreme of a spinal motion.
Thank you. We've heard that if osteoporosis is left untreated, the likelihood of a fracture is significantly increased. Simple actions like sneezing, coughing, making a sudden turn, or bumping into a hard surface can actually result in a fracture. This can be pretty scary, and people may feel like they're walking on eggshells. And then Unfortunately, then some people do stop participating in activities that they enjoy. So let's have Dr. Wu explain what fragility fractures are.
So fragility fractures, as I had alluded to before, are basically osteoporosis type fractures. And unfortunately, once you sustain a fragility fracture, it's almost by definition that you have osteoporosis, whether you've had an official diagnosis or not. So they result from low energy injuries, such as a simple fall from standing height, not necessarily a fall off a ladder or a car accident, God forbid. Like I said before, they're a common sign of underlying osteoporosis that may have gone undiagnosed. And one fragility fracture does put you at a high risk of experiencing another fragility fractures, especially in the first 2 years. And I would take that a step further to say that out of the fragility fractures, including hip fractures or vertebral compression fractures or wrist fractures or shoulder fractures, of those 4, once you have one of them, it is an 85% chance that you will get another one. And unfortunately, I see this all too often when someone comes in with a broken bone or a hip that needs surgery, and then 2 years later, 3 years later, I see them for the same thing, but now they've broken the other side. So it's not a matter of if, it's a matter of when. And that's why the information that Meryl and Dr. Wen are giving are so important, because prevention is the best treatment.
Those are scary statistics. Let's ask our audience another poll question. True or false, the most common and dangerous fragility fractures occur in the legs. True or false, the most common and dangerous fragility fractures occur in the legs. Let's see what people think, and then we'll have Dr. Wu tell us if we're correct or not. So I'll give you another second. And oh, it's about 50-50.
Wow.
So Dr. Wu, let us know where fragility fractures occur.
I think that's a trick question. So I think everyone is correct. So I think by far the most dangerous are certainly hip fractures. And so that part is correct. The most common it's probably undiagnosed or subclinical or silent vertebral compression fractures. And what I mean by that is you may have a vertebral compression fracture, but never know. And it may be picked up on a routine chest x-ray or a CAT scan, or it simply maybe you're becoming more hunched over, like Dr. Wen or Merrill were talking about. You go to get it checked out, and lo and behold, there's a vertebral compression fracture. So the most common and most frequent, or the most frequent fragility fractures occur, like I said, at the hip, spine, and wrist or forearm. Consequences on quality of life include pain, disability, loss of independence, especially if you're a more elderly patient and live alone. There's certainly an increased risk of morbidity and mortality, which we'll get into in a second. And like I said, the most serious types are fractures of the hip and the low back, especially if they cause neurologic symptoms. The 4 main types of fragility fractures that we've already mentioned would include hip fractures, which would be the most serious, compression fractures of the spine, wrist fractures, and I would put shoulder fractures or proximal humerus fractures as the 4th most common type of osteoporosis fractures, although pelvic fractures, including the ramus or things of the pelvic girdle, can also occur. Like I said before, hip fractures are considered the most serious. They're usually caused from a mechanical fall from standing height. They're associated with chronic pain, reduced mobility, disability, and increasing degree of dependence, especially in the more elderly population. A very alarming statistic is that 20% of patients actually pass away within the first year after a hip fracture, and that statistic is quite real, and I'm sad to say it, but 20% of patients that have a hip fracture, even though surgery has gone well, will end up passing away within the first year. Less than half of survivors regain their previous level of function. And what I mean by that is if you are using a cane or a walker prior to your hip fracture, you may have successfully had that hip fracture fixed, everything has healed, no complications, but all of a sudden you're more or less dependent on a wheelchair. Take that a step before that. If you were independent without a walking device before a hip fracture, after a hip fracture, you may now require the use of a cane or a walker. So it is quite a serious injury, despite a successful quote unquote treatment.
Earl, can you give us some insight about the rehabilitation of patients in that period, especially after a hip fracture, which I'm sure you see all the time?
Yeah. So I definitely agree, with Dr. Wu. For the elderly, a hip fracture can be extremely life-changing, especially functionally. It's a very scary thing for them to go through, and it's a very big rehab process. So they have this fracture. Often they've had surgery. Often they've had a hospital stay after that. So they have this period of immobility and difficulty. Sometimes before they can even go home, you might have to go to an inpatient rehab or a subacute rehab, just to learn how to do very basic things again. So you might have OT and PT in the hospital or inpatient rehab. You basically need to learn how to move again, because now you've had this fracture, you've had it repaired, and now you have to learn how to do everything again. So you have to learn how to move, you have to learn how to get out of bed, go to the bathroom, learn how to walk with your walker or cane or whatever it is that you're switching to for this time. And who knows if you're going to get off of that, you may, but you may not. You have to learn how to climb stairs again before you can go home if your home has stairs. And I think it's difficult on the patient and the family, just because all of a sudden someone who may have been independent before, now they need a lot more help. They need their child or their adult child to drive them around, and because you can't drive, or to get them to appointments and do things for them, get them to therapy. You might have a home therapist coming to your house, and then followed by outpatient. So there's many different parts, and it's a long chain of things that happen. And it is very difficult. They can do a lot. I've had many patients that have done very well, especially the more active younger ones, I would say. But there is a lot of changes in order to get back to where they want to be functionally.
Thank you for that. Dr. Wu, can you tell us a little bit more about hip fractures and incidents?
Sure. So the incidence of hip fractures increases intuitively with increasing age for both male and female. Hip fractures account for about 30% or a third of all osteoporosis fractures. It's the most common fracture for both men and women from 85 years of age and up. And rates in women nearly double compared to those in men from age 70 years old and up. And that has a lot to do with being female and hormonal issues and menopause and osteoporosis and things of that nature. The two main types of hip fractures that we do see, I have a little, this is not a real bone, by the way, so don't be scared, would be mid-cervical hip fractures or femoral neck fractures, which is this first line here. The other types would involve trochanteric fractures, which would involve this second line here. And then another type would be subtrochanteric fractures, which would involve below the proximal part. And depending on where you break dictates how we fix it. Sometimes we have to replace it. Sometimes we can fix it and let it heal on its own. But there's several types of hip fractures that we see. Vertebral fractures that we touched upon earlier, they're caused by moderate or minimal trauma that is associated with lifting or changing positions. So something even as simple as sneezing or turning the wrong way that Dr. Wen and Merrill had previously mentioned can certainly cause a vertebral compression fracture. They are the hardest osteoporosis-related fractures to define, as I allude to, because many are clinically silent. Many are picked up coincidentally on a chest x-ray for other purposes, on a CAT scan for other purposes, maybe loss of height, maybe a change in posture. And the diagnosis is based on an alteration in the vertebral body or shape and depends on where it's deformed. These types of fractures result from, like I said, osteoporosis. Depending on where it's compressed, they can be caused. Wedge fractures can occur if the front or the anterior part is crushed down. They can be classified as biconcave if the central part is crushed down, or they can be classified as crush fractures, and that's probably the most dangerous type. And that's when the entire vertebral body compresses down, and the contents of that vertebral body have to go somewhere. Well, your spinal cord is right in the back of that, and so if the crush fracture is severe enough that it causes the contents of the vertebral body to explode in the back, that can sometimes cause neurovascular symptoms, which can be very serious. The incidence of these vertebral compression fractures certainly increase with age. And again, they are higher in women than in men, simply most likely from hormonal issues. They can lead to several adverse consequences, including chronic back pain, loss of height, deformity, poor posture, immobility. These fractures, if they result in chronic pain, can certainly reduce your quality of life, resulting from loss of self-esteem, from especially postural issues, depression, distorted body image, and certainly your everyday activities, if you're in chronic pain or have deformity or you're hunched over, can be affected.
What about wrist fractures? We do hear a lot about women with wrist fractures.
Sure. So wrist fractures also occur from mechanical falls from standing height. And it happens when someone tries to brace their fall out and they land on their wrist, and that area can be commonly affected by osteoporosis. Now, fortunately, your wrist is not needed for every single type of movement like your hip or your low back. So obviously it's associated with less morbidity and mortality, rarely requires a hospitalization. They often present with deformity. So what you see on that picture, it's called a dinner fork deformity. And so your wrist actually slopes up and then back down. And many times you present like that to the emergency room. One of the orthopedists or the emergency room doctor sets it in place. And it depends on the fracture pattern, whether it needs surgery or not. And certainly it's commonly called a Colles fracture, and commonly results in a dinner fork deformity, but that's where we get that terminology from.
Wow, thank you for all of that information. Obviously, the main types of fractures and the ease at which they can occur is a bit daunting. Is there a way for us to prevent them?
So I think in general, prevention is the best treatment. So as Dr. Wend very nicely explained to us, that the way to prevent these is to live a healthy lifestyle. And that's so much easier said than done, but nutrition plays a large role, eating a well-balanced diet with levels, high protein levels, exercising, as Meryl said, weight bearing actually stimulates bone growth. It's called the Wolff's Law. It's a physiologic phenomenon. So the people that weight bear and even potentially use low weights can stimulate your body to grow denser bone. There's medications available to help minimize the risk of or rate of bone loss. And obviously environmental changes, including things like a walker or a cane or eliminating throw rugs around the house or anything around your environment to help minimize that risk of a fall, can be helpful.
Thank you. I know, given the number of women with osteopenia, osteoporosis, there are going to be a lot of people probably in our audience who have, are worried and may have already had them, or, worried about what happens then. How can you treat them once we get one?
So unfortunately, like I said before, when people come to me with a fracture, it's kind of after the fact that, yes, you have osteoporosis, whether you've been diagnosed with it or not. Sometimes it does need surgery. Most hip fractures, which is the most serious, for reasons that we mentioned before, most of them do need surgery. And depending on where you break, so for instance, if you broke along the first line, it may need some type of joint replacement. We obviously would like to optimize your nutrition with a well-balanced diet to help give you enough building blocks in your body for calcium and vitamin D, building blocks to restore bone. People like Meryl come into play with physical and occupational rehabilitation for balance training and gait training and strength training. These are all things that play a role in the treatment of these types of fractures. Obviously, managing the underlying illness, whether it be with medication or different other types of medication other types of medical entities that can cause osteoporosis should be treated. And medical treatment, which would include things like bisphosphonates, like Fosamax or Prolia, things that Dr. Wen prescribes and has expertise in, are very important. Calcium and vitamin D supplementation to give your body the appropriate building blocks to replenish and heal the fractures, God forbid. And like I said before, nutrition also plays a big role in giving you building blocks to replenish and heal fractures. And obviously, recognition and treatment of your fragility fracture can reduce the risk of future fractures by 50%. So so prevention is the best treatment.
Yeah, and that's part of why, we're here tonight, right? We really want to educate people on what to do to prevent some of this stuff. Eventually, they may have to come to you, Dr. Wu, but we're hoping to educate people to be able to prevent it. So Merle, let's go back to you to help educate us on the physical therapy aspect of it and what we should be doing should we have a fragility fracture.
So we're talking about a case where, before we discussed a little bit about the prevention, now we're talking about maybe a patient that has had a fracture. So typically they're going to start therapy once they've been cleared by their surgeon or their ortho, depending on whether it was surgical or not. After they might have a short period of immobilization or a short period of rest or not, depending on the situation. So once they're cleared, then they start mobilizing and start the rehab process and an exercise program. Our goals for rehab are to prevent falls for sure. We want to have them gain muscle strength. We want to promote better postural alignment and allow whatever body part's been affected to start moving more normally again. Our biggest thing is gaining that function back. Most people after an injury, lose a lot of function, whether it's their shoulder, maybe they can't drive or they can't reach to wash their hair. If they've had a hip fracture, they might not be able to walk without a cane or a walker. So we have to kind of reteach them how to do those things again. So therapy will definitely vary depending on what body part was injured. So, the focus for a shoulder fracture might be very different from a hip fracture, but in general, we're going to kind of talk about the things that might be included. So strengthening exercise is something that we do no matter what body part was affected, using our weights or using the resistance bands that I showed prior. We will always incorporate some type of core stabilization exercise, balance training. Most of the time, these people have had a fall leading to their injury. So we know that balance is something that's really important to work on as part of their rehab process because we don't want them to fall again and have another injury. We may teach some stretching and some relaxation techniques. We may use manual therapy techniques or manual stretching. So for example, if they had a fractured shoulder, they've been immobilized, now we're allowed to start moving it. We will start a lot of manual stretching in order to get that joint moving again. We may do exercises that will help to improve our bone health, such as walking, weight-bearing type exercise, gait training, stair training, just things to get some pressure into that affected joint again. Flexibility exercises, we'll work on that as well. And just promoting better posture and better alignment by doing spinal extensor strengthening and some back extensor exercises. So those are all some examples. Once we look at the next slide, you can see just some really nice, simple exercises that can be done very easily at home. We don't necessarily need a lot of equipment in order to do things. So this is more perhaps for the prevention exercises versus someone who's healing from a fracture or recovering. But we can kind of run through a couple of these. You can see all of the pictures here. There's no equipment needed, very simple. You could get a yoga mat at home. You could use simple things like your chair. The first one is a great example. I'm going to try to show you. I always tell my patients, especially those who work at a desk or if we spend a lot of time on the computer, every hour to try to just squeeze their shoulder blades together and just change that position. We want to get out of that forward typing position and open up, squeeze the shoulder blade. So that's a great easy chair exercise to do to help encourage better posture. It'll stretch out the front structures and strengthen the back structures. The second exercise there is also very simple. You're sitting right in your chair. You can put your arms right behind your head and you try to open up the shoulders as you're leaning slightly back, but not too far. Again, a great postural exercise. If that's too difficult for someone, maybe they can't quite get their shoulders up to where mine are. Another one that I really like that's not on the list is just called a book opening, which you just start with your hands together and you open up wide. And that's another great chair exercise if you can't quite get your arms up into that position. So these are just some great examples, simple things to do. We all want to have better posture. We don't want to get that kind of humped positioning. We want to make sure that we stay stronger in our back extensors and our scapular area, stretch out the pectoral area, and that's what all of these samples will help to allow.
Thank you very much. Dr. Wen, can you wrap up for us and give us some key points for people to take away?
Oh, absolutely. I am a primary care physician, so prevention is what I do on a day-to-day basis. And I will always believe that an ounce of prevention is worth a pound of cure. As you heard from Dr. Wu, that when we have to treat a fracture, it requires a lot to be involved in treating the fracture. And after that, there's a lot of what we call morbidity, or what we'll call is deficit that you deal with afterwards. So prevention is absolutely key. And I've always tell all my patients is that, remember, having good health requires a lifelong commitment. You can't be a goody two-shoe for 3 months and then you expect good health for the rest of your life, right? So first and foremost, whenever that you can, what we'll call is trying to follow a healthy diet and exercise regimen. Building bone is like building a brick wall, right? You need to have what we'll call bricks to stack up to build a wall. And well, you can build a brick wall and you can just stack up the brick, but they're not going to be very strong. But then you need to have what we'll call is cement in between. So example, if you just do this, one brick stack up, and you can actually, stack up another one, you can build this, but they're not going to be very strong. But if you stick glue in between, or in this case, cement, or the medication that we can offer, can absolutely build stronger bones and so forth. But obviously, diet and exercise, especially starting out when you are young. So many of these what we call healthy habits should be started when we are very, very young. And so absolutely, we can do many of these things that can help you improve your bone health. Obviously, should follow with your care provider on a regular basis to screen for osteoporosis and treating underlying diseases. Many of the diseases that we have actually can what will cause bone loss. Even the simple things, and you probably, many of you may have this already or taking the medication for reflux, for example. Okay, the antacid that we take, maybe it's Zantac, Prilosec, or Nexium, or whatever that you're taking, over the long term, they actually decrease calcium absorption, and as well can predispose you to osteoporosis, kidney disease, thyroid disease, parathyroid disease, anemia, you name it. There are so many medical conditions that actually can put you at risk for developing osteoporosis. Asthma, if you have severe asthma, you have COPD, and I can tell you, if you say, well, even blindness on people have decreased vision are at increase to developing osteoporosis. So why is that? Well, if you don't have good vision, you are less likely to do what will cause other physical activities like other people would do. You're less likely to get involved in those physical activity, and as a result, you are at higher risk for developing osteoporosis. So there are absolutely many, many different ways that you can try to follow and improve your bone health.
Thank you. We will take time now for questions and answers. So let's start the first one. Merle, this one is for you. A person wondering if you use the principles of the physical therapist Sarah Meeks, who emphasizes posture and trunk flexion avoidance. Apparently she has focused her career on osteoporosis and safe exercises. Do you know her and use that?
I wouldn't say that I know of her specifically, but I think, just talking about the principles that you just said are things that we would certainly follow, because I think she's kind of referring to the neutral spine as far as avoiding those high movement positions, too much flexion, too much extension. We know it's a little bit safer to be in that neutral spine position. So I know there are many Pilates and yoga type exercises that can be performed in a neutral spine position. So when we do therapy, we focus on those safer positions to work on strengthening. So I hope that answers your question.
Thank you. Dr. Wen, I think this one is for you. Is Prolia marketed and prescribed to women only, or can men use this medicine as well?
No, it can be used for both when that is necessary. I would say that because osteoporosis is much more common in female, and as Dr. Wu mentioned it before, and female suffer osteoporosis fracture twice as often as men do. but Prolia can be used for both men and women when other medication are not adequate or people cannot tolerate some of the medication, and they're well known like Fosamax or Boniva and so forth. If they cannot tolerate those, Prolia can be used, but there are other options as well, more than just Prolia.
Okay, thank you. Dr. Wu, this one is for you. Several years ago, I tripped while walking and broke bones below her elbow in both arms. Would this be considered a fragility fracture?
It depends on where in the forearm that you broke. So by definition, if you broke the distal radius or a Colles fracture and you broke right around here, yeah, by definition, that's a fragility fracture. And if it occurred from standing height, if you broke your forearm because you were doing a cartwheel and whatever, then by definition, that's not a fragility fracture. But if you broke your arm here because you fell from a standing height, and it was a wrist fracture, yes, by definition, that's a fragility fracture.
Thank you. Dr. Wen, if you start a medication for osteoporosis like Prolia, are you on it for life? And then as part of that, there's another recast is a once-a-year infusion. Is there a limit or is it for life? So recast and Prolia.
So these medications are typically not for life. Even some of the medication that people take, for example, Fosamax or Boniva and so forth, they are often at this time in our what we call is medical history. We know that people should not be on it for longer than 5 to 7 years or so, often because that's actually more does not necessarily mean better. Prolia often is used for maybe about 2 to 3 years, and we can measure the bone and see how effective it is progressing. And if it's no improvement, we may not use it at all. So Prolia is actually one of the injectable that is available, which is now used at twice a year. There are injections that you do actually once a month, but it's only for about 1 year, for example. And then there are injections that are available for people to use actually one a day, every day for about a year as well. So there are various options, and there are infusion, and then that question probably referred to a medication called Reclass. And again, that is also used just for a short few years.
Right. Given the potential for serious side effects from the biphosphonates, including necrosis of the jawbone and femoral fractures, we have an attendee who would like to know, are these meds usually used as a last resort, or do we use them anyway, knowing that those are potential side effects?
Okay, so the bisphosphonate, as you mentioned, they do carry the risk of what we call necrosis of the jaw, although that is very, very rare. And is I would say that I have never seen it in clinical practice, what we call ambulatory care. They are much more often associated when people are being treated for certain type of bone cancer or something. They get an infusion when they are in the hospital. So that can actually induce a condition called osteonecrosis, or basically dying of the bone of the jaw. But in ambulatory setting, that just does not occur, and that's usually not a big concern. So no.
Okay, thank you. In how much calcium and vitamin D should you take daily?
Well, that's also depending on the person, and I would say in typically you do it for people who have what we call osteopenia. That means that the bone is a little bit thinner than average, but not meeting the definition of osteoporosis. I would say probably up to about 1,000 milligrams of calcium per day should be plenty, and that's including either supplements or you can actually get it from the diet. Actually, dietary calcium is preferred over supplement. So your milk, your cheese, your yogurt, and so forth, if you can consume those in adequate amount, then you may not need to have supplement, because the dietary intake calciums are actually better at building bone than those supplements. And when we actively treating people with osteoporosis, we typically use somewhere around 1,200 milligrams to 1,500 milligrams of calcium per day, along with vitamin D. And it's also a person who has vitamin D deficiency may need higher dosage of the vitamin D. There are typically about 400 units of calcium, 400 units of vitamin D that is incorporated in some of the calcium supplements. So let's say you have 500 milligrams of calcium, and then you have 400 units of vitamin D in there. So you take that twice a day. That's how we add calcium supplement to a treatment regimen.
Another question is, I heard there is a medication you can get by injection. Is it true, and how often do you get it? I'm worrying about taking oral medications because of esophageal cancer. I guess, Dr. Wen, that's for you as well.
Yeah, so unfortunately, the bisphosphonate, as you mentioned before, such as the Fosamax or Boniva, they do have some side effects, what we'll call gastrointestinal side effects, that is people having trouble with reflux or heartburn. If you take it as instructed, those side effects are actually pretty rare as well. And if you follow the instruction to the T per se, they're not very common. But if you have condition that you cannot take those medication, then you can go into the injection. The Prolia, as I mentioned before, is actually used once every 6 months. There's Forteo, is actually a small little injections every day. And Evenity, that's 1 injection per month for about a year. A Reclass is actually an infusion at an infusion center. So that cannot be done at home. It has to be done in an infusion center. And that's typically done once a year. Okay, but there are other medications you may have heard it too. There's a nasal spray called myocalcin, which is basically derived from a salmon hormone that can be used to treat osteoporosis as well, although they're not as effective as some of the medication we just mentioned, but that's also an option.
And how about, have you heard about vitamin K2 and MK4, which this attendee says are being used in Japan? And what are your thoughts if you have heard of those?
So I have heard of them, but don't have really much experience. I would say in the United States, we often practice what we call evidence-based medicine. So we typically, I do not prescribe those. That is not approved by the FDA here in the United States, but certainly some of those treatments are available. And then some of the treatments are actually available in other countries before they come to the United States. So those may be coming to the United States soon, but currently I do not have adequate information on those.
Okay, thank you. Meryl, how do you get physical therapy? Like if somebody wants physical therapy or needs physical therapy, how do they get to you?
So mostly if someone wants to start an exercise program because they're fearful of doing it on their own, that they might do the wrong thing, they would typically need a prescription from their doctor if they are getting covered by Medicare. There are some insurances that do allow what we call direct access for physical therapy, where you can come right in the door without a prescription and get seen by your physical therapist and get an exercise program. Medicare does not allow that at this point. So my advice would be for most people with their insurances, you want to go see your primary doctor. You want to, discuss your current situation, what's safe for you. And then if your doctor agrees, then they can send you a prescription for physical therapy. It might say deconditioning or for weakness, or if there's a certain area that the doctor and you would like us to work on. And then at that point, then you come in to see your physical therapist, schedule an evaluation. And then we do kind of a full evaluation based on that prescription from the doctor that you've discussed. And then we develop your program from there based on what's safe and what we need to work on.
Thank you. Another question. What do you think about jumping rope for weight-bearing exercise? I enjoy jumping rope, and although I have osteoporosis in my spine and osteopenia in my hips, I've never had a fracture, and I'm 58.
That's a tough question. So I think my answer would normally be, if you have osteoporosis or osteopenia, I would not recommend that type of activity because it is considered a very high impact activity. And based on information that I have gathered, it would be not recommended. Now, that being said, if this person has done it their whole life and they're currently, doing this exercise and they're safe and they feel comfortable, I'm sure it's fine. But it's just something to be careful about. Especially someone who has osteoporosis, my other concern would be, what if you accidentally tripped on the rope and you fell down and you're already osteoporotic or osteopenia? Would you then sustain a fracture from tripping on the rope? because it is considered a little bit more of a dangerous, higher impact activity, such as running. You know, some people might be runners at 58 and not want to stop that. So I can understand that. I think it's just, you know, you need to be safe in a safe environment. Maybe a runner, for example, might run on a track or versus running on hard pavement. So there are some modifications I think that can be done. But in general, if you're already osteoporotic or osteopenia, I would say it would not be recommended to do jump rope.
Very good, thank you. I want to be respectful of everyone's time. It's 8:01. We have one more question. How accurate are DEXA scans?
So DEXA scan, I would say that at this point in time, it is so-called the standard of care in terms of diagnosing osteopenia or osteoporosis. So it's actually the most accurate. Is it 100%? I would say that not too many things in medicines are 100%, but it is actually very, very accurate and very easy to do. And it's very, very simple and fast, and it is very accurate.
Thank you. Does anyone have any closing remarks? And if not, then I'd like to thank the three of you for joining us tonight. Very, very nice presentation. For those of you who can see the screen, obviously, if you need to make an appointment with any of our physicians, and again, we told you how to get in touch with Merrill. Their numbers are on the screen. Obviously, these programs have some planning and background work that gets done. So thank you to Susan and Lauren for all the work that they always do to put these programs on for us. Our next Spirit of Women program, it will be on June 10th, and it's entitled Running Through Your Veins. We will have Dr. Holly Graves discuss vascular screenings and their importance to our staying healthy. We hope to see all of you in person again soon. I know they're relaxing a lot of the restrictions, but I want you to continue to stay safe, stay home if you can, wash your hands, wear your masks when you need to, indoors. I think some places are still requiring them indoors. And thank you for participating for us tonight. We hope to see you soon. Thank you for our panelists.
It's certainly a pleasure, and we'll hope to see you all soon. Please stay well.
Thank you.
Thank you. Have a good night.
Bye.